In South Dakota, we have a significant American Indian population, which brings diversity to our state, but brings unique healthcare challenges. Diabetes and the American Indian tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Diabetes is rampant in the general American population, often due to obesity, inactivity, and poor diet. In the indigenous population of American Indians, there are additional factors at play. The history of what happened after the European conquest, economic factors, and current social pressures that are felt by the American Indian community are just some of the contributing elements. First, let's take a look at this week's Prairie Doc quiz question. True or false, American Indians and Alaskan Eskimos are twice as likely to be diagnosed with diabetes as the general population? True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for the show back then, is accompanied by a lovely photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to answer the question. But we answer your questions as they are called in or sent to us via Facebook or email all night long. Call in your questions to 1-888-376-6225 or send an email to the address that's on the screen here. Joining us tonight are Dr. Donald Warren, who has degrees in both medicine and public health, serves as chair and associate dean for diversity, equity, and inclusion, plus is the director of Indians into Medicine, the InMed program at the University of North Dakota in Grand Forks, North Dakota. Thank you for joining us.
Yeah, very happy to be here.
Great. And we have Valberg Kavingi. I know there's a lot of ways to say that, but I kind of like the lilt of the Scandinavian thing there. The coordinator of the Department of Medicine, Family Medicine at USD Sanford School of Medicine. Thank you both for joining us.
Thank you.
Before we dive into this, I wanted to make a comment about my health. 2 weeks ago, yesterday, I had surgery at the Mayo Clinic where they took a slice out of my liver and removed a metastatic lesion from the pancreas. The CAT scan, or the PET scan did not show evidence of other spread after the surgery, and we sense that there's a reasonable shot at maybe getting it all. I know full well the chances of it coming back, but there is a chance that it won't too. So that, I thought I would update the people about that. I'm no longer on chemo. My hair's I don't know that I'm going to reach your level of hair growth, Don, but I'm going to have a little bit of hair coming back, so I'm pretty happy about that.
Yeah.
So let's start with you. Tell us a little bit about what your role is at the School of Medicine, please.
Yes, I work with the tribal diabetes programs, and I help the programs with data analysis and program evaluation.
So you're that research guru kind of person where you crunch numbers. Actually.
Yes, yes. Mm-hmm.
And so you've been doing a bunch of different kinds of research?
Mm-hmm. Yep. Whatever the tribal programs ask me to do, I try to do that for them. So if they want to see if there's improvement in fitness levels of the participants that they're working with, or if they want soda survey that's
how much soda people are drinking,
yes,
those kinds of things?
Yep, I'll do that for them. If they're doing a survey for to increase the number of men that participate in their programs, so I'll try to find out what the needs are. So I'll do those survey results. So I basically do whatever they ask me to do.
So these are tribal health programs that are in different reservations.
Yes.
And that's different than the IHS?
Very
the
different.
Indian Health Service?
Yes, very different. The tribal health programs are totally separate, and they set their own goals, their own objectives, their own program. They develop their own programs, and
they're all local. They're
They're
local
local.
in their reservations.
Yes.
And they do their own work. And you help coordinate things.
Well, I help them with the data analysis.
Now, the School of Medicine is doing that. I mean, you're employed by the School of Medicine.
Yes.
But we do other things with them, don't we, through the School of Medicine?
Yes, absolutely. We offer students, medical students, the opportunities to go out to the reservations to complete projects, so they have an opportunity to work with the local people. And I've worked with 2 students that actually did a research project, and they went to the Tribal Institution Review Board to request permission to do the study. The Tribal IRB was very, very helpful for the students. They offered suggestions as to when they could do the survey, community events where the students could collect surveys. I mean, and then they offered tremendous support to see the results. So they were very, very supportive of the students, which really encouraged the students to continue with that project.
Oh, that warms my heart and feels really good.
It was.
So Don, your history is interesting. Your tribe, you have a tribe, right? Your original tribe is from where?
From Pine Ridge, South Dakota. So I'm Oglala Lakota. I'm originally from Kyle, South Dakota.
So Kyle, and it's interesting, we were talking about, I said, well then aren't you, this is a Sioux Indian, and you corrected me. This is Oyate. Now explain that to me.
Sure, so we call ourselves Oyate. So the Lakota, Dakota, and Nakota tribal groups are part of a larger group. We call ourselves Oyate, or the people. And we were renamed Sioux, S-I-O-U-X, but that's actually the French renaming of our tribal group. And the word Sioux originally comes from an Ojibwe word that means snake or enemy. So typically we don't like to call ourselves Sioux Indians because of that.
Which means the enemy.
Exactly.
And
yeah.
I mean, it was the white guys who really pushed this name upon
particularly from France, which is why it's spelled S-I-O-U-X.
Yeah.
It's got a French spelling, but
So-
that's not our original name for ourselves.
Oyate.
Yeah.
Dump the word Sioux. Oyate is the right way of saying it.
We'd have to call it Oyate Falls, South Dakota.
Oyate Falls.
Wouldn't
There
that be
it is.
wonderful? Yeah.
So now you were originally from Pine Ridge, but then there's a story there. What happened?
Yeah, so I have family originally in Manderson and Kyle, and my great-great-grandfather was Chief Stabber from Kyle, South Dakota, and he was part of the delegation of Oyate leaders who went to Washington, D.C. back in 1872. So I always like to say that advocacy is deep-rooted in my family, even going back to the 1800s.
Yes.
when my great-great-grandfather was actually part of that delegation. But when I was in grade school, we moved to Arizona. So I spent most of my childhood in Arizona, but would come back to South Dakota during the summers. So growing up, I just assumed that every kid went to South Dakota for the summer, but it turns out that's not the case. Right? Okay.
But it's a
Come
great
to learn
place
that.
to come for the summer.
It is. It's a magical, beautiful place, but I was very fortunate to be from a family with a lot of medicine men and traditional healers. So when I would come back in the summers, I could spend time with my uncles who would teach me and my brother and other family members
The traditional
ways and ceremony and all of the beautiful, wonderful things about our culture.
See, so then here you are not only a physician by training and a master of public health, but you are also trained in ancient medicine man activity or medicine woman activity. Was that a woman and a man option?
Yeah, so we would have traditional healers. It could be men or women. So growing up, I was able to learn a lot about our traditional ways. And my grandfather, Louis Stabber, his Lakota name was Prejutawichasha, which does mean medicine man. And when I was younger, I was given his Lakota name in a traditional ceremony. So my Lakota name is Prejutawichasha, which does mean medicine man. So I'm not a medicine man, I'm not saying that, but that's my Lakota name. But I do participate in our traditional ceremonies and really embrace the role of traditional approaches to counterbalancing some of the negative impacts that have led to health disparities.
No, there's a lot of health disparities. I mean, that's one of the things that we see. There's health disparities, though, that I think mostly come with poverty.
Yeah.
And one of the things that I was wondering, because the essay is about poverty, my thinking is that there's a trap of poverty that occurs on the reservation, partly because of ownership things. Can you explain that a little bit, Doc?
Yeah, so there's a lot of challenges when we look at poverty, and I think one of the social determinants of health that links health disparities together is poverty. And when you have less resources, you have less access to healthy food, less access to physical activity programs, less access to good education, less access to medical care. So all of these social factors that can lead to poor health outcomes do have a commonality in poverty. Now the challenge from an indigenous perspective, when we think about poverty today, there's two measures. One is income, money, and the other is land ownership or home ownership. So think about that from an indigenous perspective. We never had a system of money, and you think about money, it's an artificial proxy for value.
Right.
And it used to be we were on the gold standard, and a dollar bill was a silver certificate. You could trade your money in for precious metals.
Yeah.
We no longer have that standard.
No.
So you know what backs up our monetary system? Nothing.
Nothing.
Not a thing. So what actually backs up money is our collective belief that it has value. From an indigenous perspective, that's silly. That's really crazy because we drive decisions. People live or die based on this man-made invention of currency. So it's a driver of health disparities, but it's also a foreign concept from a cultural perspective. Then you think about home ownership and land ownership. We never believed that we owned the earth. That's really a foreign concept as well. And if you think of the earth, been here for billions of years, in the sliver of an instant that is one person's life, they can believe they own the earth, and then they'll die, and the earth will be here for billions of years. So the idea that we own it is also quite silly. So the whole idea of poverty really does have cultural roots that was very foreign to us as indigenous peoples.
Part of what I've heard, though, is that employment is very difficult on the reservations because businesses can't go in because you need to be able to buy some property so they can build a building or sell a product or whatever it is. It doesn't work. I mean, the ownership is a difficult thing.
There are some examples where that can work, but in many ways it's like going to a foreign nation, and the challenges of working in foreign nations, you don't necessarily own the land that you're putting your factory on. So there are challenges that way, but what I would like to see is more tribally owned businesses, because in truth, with the world as it is today and American society, we do see correlations between economic development, poverty, and health outcomes. And I really think that economic development is a public health intervention. So I'd love to see more tribally managed and owned businesses.
Right. On the essay that I wrote that you'll hear later, I talked about, with my research, I looked at the options of what we need to do in this country for the people who are in poverty. Part of it is to make sure that the people who are disabled are protected and that children are protected. The other, you try to have employment for everyone if they can have it, and that finally, the most important thing is education. And I think preschool education is the most important thing we can have, and then postgraduate education. 2 years ago, you and I were together on a show, and I was saying, well, the Indian health system, has so many problems. Maybe it's something we should throw away and start anew. And you came back with, and I'd like to hear you describe this. Why do you think that Indian health system, IHS, struggles so?
Well, there's many reasons. One is just chronic and long-standing underfunding. So it's just been terribly under-resourced, and any system that's under-resourced is going to have struggles. So the truth is, we don't know if the IHS system is good or bad. It's never been fully resourced. So it's not a failed system, it's a starved system. And the analogy I use is if you have a car that needs a full tank of gas to get from point A to point B, and you're in charge of filling it and you only fill it halfway, if you run out of gas before you get to your end point, you can yell at the car, you can yell at the road, you can yell at the driver, or you can look at who's responsible for filling that tank, and in this case it's the US Congress. So in this circumstance, it's the United States Congress that makes policy decisions to underfund IHS. They are to blame in this circumstance, but we blame the road, we blame the driver, we blame the car.
Well, your example of funding was how much money do we spend for every Medicare patient? Why don't you go through that?
It's over $12,000 per person per year for Medicare. It's around $8,000 per person per year for Medicaid. It's about close to $9,000 per year for Veterans Administration beneficiaries. Federal employees, that's over $6,000 per year. For Indian Health Service, it's around $3,000 per year. So it's about 1/4 of what Medicare recipients receive in terms of access to resources. So we just simply run out of resources to provide adequate services.
Well, you know, the government has a responsibility to support the resources because of what reason?
Well, treaties for one. So we have hundreds of treaties that are signed between the tribal nations and the federal government. And the treaties promise things like all proper care and protection. So in exchange for land and natural resources, we are owed all proper care and protection. And because of the supremacy clause in the US Constitution, treaties are considered the highest order of law in the land. So we have a legal right to health services. So when I hear people say Indian Health Services free health care, I beg to differ. Actually, it's the largest prepaid health plan in history. I like to remind people, if you want to get rid of Indian Health Service, that's fine. Just give us our land back.
Yeah.
I don't think that's going to happen anytime soon.
No,
but
no, it
that
won't.
would be the equivalent.
Well, what about, and plus the other side of it is the education system that we promised with the treaties, right?
Yeah, so in exchange for land and natural resources, there's various social services, including housing, education, and healthcare. So that's why, for healthcare, that's why there's an Indian Health Service. For education, that's why there's a Bureau of Indian Education. For other services, that's why there's a Bureau of Indian Affairs. So there's actually treaty and legal basis for these agencies that are responsible for delivering those services on behalf of the federal government.
So part of the poverty issue has to do with underfunding.
Yeah.
We can go to that. Here at On Call with the Prairie Doc, we strive to deliver information that is based on good science. Sometimes science can fall short of our healing or well-being. Viewing or creating art in many forms can have very healing properties, and that bridges the gap to our wellness.
As a viewer, responding to art, seeing art, or even engaging with art, if that's the type of art form, it's going to allow you to have this sense of well-being, this sense of connection, also this sense of purpose. And then I think through that, you gain more strengths in humanities, but also critical thought is really heightened. So you're also accepting a different perspective that you might not normally give an opportunity to hear, or even to allow to be an opportunity to confront you, but you're willing to take that in, and maybe you find something that helps you. Maybe you feel that sense of well-being, like I said, after just engaging with the art through as a viewer. And then the second part would be actually practicing art, making art. The process of an art form, whether it be drawing, beading, or gardening, or dancing, whatever it may be as an art form, having that practice engages the body. And I think it awakens these spiritual energies, or these metaphysical energies that exist within the human body. And it gets people to actually practice life, just live. And that can be rewarding in all kinds of other fields as well, too, I think. And I think mental health wise, you're always going to have something that you're focusing on. And there's always going to be something that's just exercising your brain. So that's going to be really beneficial as well, too.
That was wonderful, Keith. Thank you for sharing that information. I think about the heart and the soul of what makes a physician caring and understanding, and it has a lot more to do with that art part of your brain than all that science. It really is an important concept. Any comment about art in medicine that either one of you would make? Don?
Well, certainly I think that medicine is more than just a science. I think the way we connect with people is very meaningful. And one of the skills that our traditional healers and medicine men have is the ability to connect on a more emotional and spiritual level as well. Yeah, and I think a lot of that is reflected in our art. It is an expression of spirit and an expression of emotion. So it is all connected together, but we tend to separate it in modern times.
You know, with this cancer of the pancreas, a lot of my heart and soul is thinking about the spiritual aspects of things, and the closest I get is when I'm singing with a choir. Part of this whole story that we're talking about is diabetes. And a lot of it has to do with the foods that we eat. Whoever has diabetes part of it is exercise and the other part is eating right. What do you know about food and on the reservation and programs like that?
We have several of the travel programs that have community gardens, and some of the programs have even collaborated with USDA and some of the other federal government agencies to put in raised beds at people's homes so people can start to garden and grow their own food. And it's not just about growing food. When you're working outside and you're working in the garden,
You're active.
You're active, but it's also it releases stress. It's part, you know, it's just a way of feeling better about yourself and having the experience of experiencing nature.
Do you have a garden?
I do.
I kind of sensed that was the case. Don, do you have a garden?
Yeah, we do. We just moved to a new house in Grand Forks. We haven't set it up yet, but we had one when we were in Fargo. So we're planning to reset up our garden. Yes.
Yes. I have a garden too, and my wife has more the flowers. She's more the beauty. I'm more the tomatoes.
Yeah.
You know, hot peppers. But the value of good food is so important in diabetes, and one can argue that part of the problem has been a result of the kinds of foods that people eat on the reservation. Commodities, for example. Talk to me about that. I mean, either one of you, Don?
Well, when we think of traditional food now, a lot of people think of fry bread, right? But fry bread is not a traditional American Indian food. We never fried dough, right? And it's basically people doing the best they can with their commodity food. So through the USDA, there is a commodity food program, and specifically a food distribution program on Indian reservations. And when I was growing up, it consisted of things, you know, like flour and sugar. They called it grape juice, but I think it was just sugar water with purple food coloring.
Yeah.
You know, some sort of spam-like meat product. I'm not sure exactly what that was. They used to distribute pure corn syrup. On the label, it says use in your baby formula and use on your pancakes. So it's actually the distribution of poison. And in many ways, it's pre-packaged diabetes. So what people would do is fry the bread, the dough, and made fry bread because that's the best they could do with their commodities. But it's not traditional American Indian food, that's traditional USDA food.
There you go.
And convenience foods. That's another.
In modern times, that is absolutely true.
That's a problem because there's so much more sodium that the portion sizes are just out of control, and so the prepackaged foods are not a good thing. And frequently, you'll see just a small area for fresh fruits and vegetables in the stores locally, and so if someone living in one of the reservation communities wants more variety, they generally need to go to a store off the reservation to find a wider variety.
Yeah, which is the whole idea of a food desert. You know, so in the communities, there's no access to local healthy food choices, and so when we say fresh fruits and vegetables, I have to put that in quotes in terms of fresh, what's available locally. There's also a concept of a poverty tax, and people who live in impoverished communities pay more money for fruits and vegetables than people who live in cities. So it's just more expensive because it's perishable and has to be shipped out there. So it's not a shortage of access to calories, it's a shortage of access to good nutrition.
Yes, here it is. This is your program, and your questions are key to the direction of our discussion. So call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org, and we have some questions. A woman from Sioux Falls asks, or from Oyate Falls, asks, are there circumstances where the A1C cannot be controlled? Hemoglobin A1C is a measurement of 3 months of sugars, and it gives you an idea of how well that person's blood sugars are controlled on average for 3 months. So
yeah, well, so in my own experience, I'm a family doctor, and what I have seen is that for the vast majority of people, we can control the hemoglobin A1C and control the blood sugar. The challenge is whether or not we have the resources to do it. So it includes, of course, access to good medications, but it also includes access to the right foods. It also includes developing physical activity as part of the prescription for management. So I think it can be controlled for the vast majority of people, at least in my own experience. That's what I've seen. So yes, there are things that we can do, but quite often poverty limits access to improved outcomes. What do you think about that?
Yeah, I think it can be controlled. And I think it's important for people to be cognizant of what their numbers are and to be working toward that.
Although I think that our average hemoglobin A1C, you know, what has been promoted, oftentimes is promoted by the pharmaceutical industry. They want it lower, lower, and they want more drugs. But what has been shown, particularly in the elderly, is that the hemoglobin A1C 7.5 is really pretty good. And to try to push people to 5.5, that's ridiculous.
Yeah.
And you know, people who and unimportant medications should not take priority over the important medications. So there's a lot to be said about choice of medicines. And
Yeah, absolutely.
a woman from Brandon asked, can diabetes affect your thyroid? Don?
Well, actually, it's kind of the other way around. Usually, if you have low thyroid levels, it can put you at risk for type 2 diabetes. So
Your
we do
metabolism
see
turns down.
Exactly. So hypothyroidism or low thyroid can have a correlation to higher rates of type 2 diabetes.
A Brookings caller asked, when South Dakota opted out of Medicaid, would that not have been a good system to help IHS as opposed to going bankrupt?
So that's a wonderful question. So actually, so it's Medicaid expansion. So we do have Medicaid in South Dakota, but most people don't realize is Medicaid only covers impoverished children and pregnant women. There's a lot of non-pregnant women, and there's a lot of men who live in poverty that don't have access to health insurance. So what we've seen in North Dakota, where we did expand Medicaid, is tremendous increases in access to services relative to South Dakota. It'll take probably a few years to see changes in disease outcomes, because that doesn't happen overnight. But my sense of it is just looking at access to services as a proxy. American Indians and other impoverished people in North Dakota are going to be doing a lot better than those in South Dakota because we did not expand Medicaid here. And what I like to remind our fine residents of this state, we're helping to subsidize Medicaid expansion in other parts of the country because we still pay federal taxes, but we're just not reaping
We're
the
not getting the
benefits.
money
Yeah.
from the federal area to pay for the Medicaid expansion.
Yeah.
I think it's an outrage. I've just been infuriated about it, and because it could have brought all those people, the working poor in particular, better access to health care. But we didn't want to start it because once you start it, then you're stuck having to do it, like cover people who for their illnesses.
And it's written into the law that at most the state would pay 10% of that bill for the new Medicaid enrollees. What other opportunity do we have to spend $1 and get 9 in return? What other opportunity do we have to do that?
And you talk to a legislator, they get mad.
Yeah.
And so here it is, two mad people talking.
Yeah.
I find myself, this is so frustrating, but I'm happy to, I have the pulpit right now, and I'm very frustrated about expansion of Medicaid, and we should have had it.
Yep. I agree.
A viewer from Oyata Falls.
All right, Oyate Falls, very good.
Oyate Falls says, please have the guest comment on role gambling plays on reservations and how it supplies funding. So do you have a comment about gambling?
I don't know.
Okay, so Don, I bet.
Yeah, so it's fascinating because we do have casinos in many of our reservations, but they're not the types of casinos that are in other communities that are thriving and making lots and lots of money. Most of our casinos are basically just surviving and employing people, so that's a good thing to having employment. But it's certainly not a long-term solution financially. And in truth, when we have people who are employed and get health insurance, that's a good outcome, whether they're working at a casino or a restaurant or what have you. The difference is that other communities in other parts of the country where there's a lot more customers, like in a suburb like Minneapolis, in that area, we can see highly successful gaming operations and resorts and hotels. But if we think about like where I'm from, there's just not a huge population base of people to draw from to make a highly successful casino. So
it's
I think
not an answer.
It's not a long-term solution to financial needs. That does have some benefits though. It generates some revenue and it does generate some jobs. So there's some positives associated with it, but it's certainly not a long-term solution.
What's your comment about the issues of employment on the reservation? Any thoughts that you would have about it?
The people that I work with are super good. The employees that are in the tribal diabetes programs, those are basically the only ones that I'm familiar with and that I'm working with.
Hardworking, good people.
Very, very much so, very much so. And they try really hard to make an impact in their community to improve the health outcomes. And so that's been my experience with the people that I've worked with.
Now, we were earlier talking to the pre-professional students out there, and one of the questions had to do with obesity as a genetic tendency, and of course the Pima Indians have a high penetrance of obesity. And I said to you, is that a genetic thing? And your answer was what?
Well, there's probably a genetic predisposition to diabetes risk, but I wouldn't say it's a genetic disease because it's not inevitable. There are some genetic diseases that we're going to get no matter what we do, but when we look at populations, whether it's here in South Dakota or Pima Indians in Arizona, there was not a high rate of diabetes just 40 or 50 years ago. So we didn't see a genetic shift in that period of time. What we saw is a dramatic change in lifestyle and dramatic change in access to healthy food, for example. Commodity foods have a much bigger impact than genetics, and we haven't identified a gene or even a series of genes that are linked specifically to diabetes in American Indians. There's certainly probably genetic risk for the disease, but when we hear something's genetic, we think it's inevitable, and diabetes is not inevitable in American Indians.
And when we talk about obesity, one of the programs was working with their participants, and the participants were having difficulty losing weight. So they decided they wanted to do a survey on soda to see what % of the people in the community drink regular soda and what % drink diet. And so I did the analysis for them, and they found a very high % of men and women are drinking soda, which contributes to a difficult time losing weight.
With the corn syrup sweetener.
Yeah, but just walking across campus today, I saw several students walking with their bottles of pop.
Yeah.
And so
it's everywhere.
It's everywhere.
It's everywhere. And I've seen studies that show that there isn't a difference between obesity, whether they're drinking diet soda or sugared soda. I mean, it just seems to run together.
Mm-hmm.
Yeah, sugar-sweetened beverages really are just a terrible outcome in this country, and it leads to all kinds of health challenges.
Lots of health challenges.
Yeah.
Yeah, before we go any further, I kind of wanted to, we were enjoying this Oyate story, Sioux Indian meaning snake, and Oyate meaning that's the
people.
That's the people.
Yeah.
Other words, Minnesota, where does that come from?
Yeah, it's very interesting. Most people don't know where the word Minnesota comes from, but the Dakota people did live in what is now Minnesota, and Minnesota is actually a derivative of Dakota words, mni meaning water, and shota, which means smoky or cloudy. So a mni shota is when the smoke or clouds appear to rise off the water. So this time of year when we see that, the smoke rising off the water is a mni shota. So it's literally the land of the mni shota is Minnesota.
In Minneapolis.
Yeah, and isn't it interesting with Minneapolis, when you say the word Minneapolis, you probably don't realize it, but you're being bilingual, but in this case, Dakota and Greek, because polis is Greek for city. So Minneapolis is Dakota Greek for water city.
Water city, Dakota Greek.
Yeah.
And South Dakota, North Dakota, I mean, it's Dakota, but there's the Dakota, Nakota, Lakota.
Very
Explain
good,
that.
yes, yeah. So as our Oyate, the Dakotas were further east, Lakotas further west, and Nakotas further south. And because colonization came from the east, the colonizers encountered the Dakotas first. So that's why it's North Dakota and South Dakota. If they had come from the west, it would be North Lakota and South Lakota. So this wouldn't be SDSU, it would be SLSU.
There you go.
Yeah.
There we have it. We know the things we should do to live with diabetes from a medical perspective. The way we relate to our society, our worldview of our culture has got huge influence on our well-being too. A new initiative through the USD Center for Disabilities provides an educational outreach effort focused on Native Americans.
part of what we're wanting to do at the new Oyate Circle at USD is to address some of these elements. The disability awareness training grant that we got funded is providing on-site training to communities, and naturally part of our curriculum and teaching and focus includes diabetes because of the high prevalence that we have in our communities. We want to try to do what we can to impact some improvements in the diabetes rates through awareness training and other elements in terms of how we can take care of ourselves through our diet, our exercise, what we can do proactively as community members. But also we need to make sure that people are aware of what they're ingesting and how that's impacting their future disability impacts. We have produced a couple of videos, one with some general information on disabilities, one with diabetes, and another with learning disabilities, some of the prevalent disabilities that we're dealing with. So we want to have PSA type of things that we are producing currently through the Oyate Circle, so that various organizations can utilize the video information to share with their clientele or the folks that they work with. And also we plan to be at all 9 reservations over the next 2 or 3 years doing on-site disability awareness training that will include a diabetes component, so that folks can get some information and some ideas and how to implement some of these new medical technologies that may or may not be available. But as much as we can, we just want our communities to be aware so they can be proactive in their self-care and prevention of diabetes. Through my WSD Productions, which is a division of Warrior Society Development, I was able to produce a film titled 7th Generation. And it addresses some of the history of my people, but also the prophecy that Black Elk had regarding the 7th generation, that our sacred hoop, our circle, will be healed after 7 generations, and that is representative of the youth of today that we have in Indian country. So it's a very exciting time from the prophecy, because we're starting to see many of our young people step up and get out of that cycle of despair, if you will, and start seeing some of the positive elements that can be out there, kind of the light at the end of the tunnel. When I work with the young people, I want our 7th generation to have every opportunity to succeed and let that prophecy come to life. And I always say one of the things that I believe in is that someday one of the members of the 7th generation will be president of this United States. And wouldn't that be wonderful? That'd be a complete full circle to have a tribal member in the White House. So wouldn't that be interesting?
I hadn't heard the 7th generation story. I mean, the 7th generation is right now, isn't it? And that's a prophecy by Black Elk, with the wonderful book Black Elk Speaks.
Yeah, exactly. And actually what we're taught in Lakota and many tribes is to pray for 7 generations ahead. So in the time of Black Elk, and he was a survivor of the Wounded Knee Massacre in 1890, that is what he said, we're praying for 7 generations ahead, and it will take 7 generations to heal the broken hoop. And I agree with my brother. That's my brother who was just speaking. And we're seeing a lot of positive movement in our tribal populations, much more self-determination in healthcare, more education, more opportunities to heal our communities. And I think that that's just consistent with our cultural belief systems of praying 7 generations ahead. And for me personally, and what I was taught, is think of all of that strength that 7 generations ago they were praying for me. They were praying for you. They were praying for all of us. And I take a lot of strength in knowing that 7 generations of people were caring for us.
So, with that positive note of the changes, the strength that's coming, the sense that they're pulling out of this, tell us about what your effort is in med.
Yes, absolutely. So at University of North Dakota, we've had the Indians into Medicine program for quite a few years. 1973 it actually started. And we've now graduated 239 American Indian physicians out of the University of North Dakota. So I'm director of InMed, and we enroll 7 enrolled tribal members into our medical school every year. So at any given time, we have around 28 medical students at University of North Dakota. And we have a good collaboration with the University of South Dakota. So there are several students that are actually at USD and InMed as well. So my sense is that over the next generation, we will see significant increases in the number of American Indian healthcare professionals, because we need to take ownership of this and solve the solution, create the solutions ourselves.
Yes. Any comment, Valberg, about South Dakota?
Well, as far as taking ownership and working hard to make improvements, that's what I see in the tribal diabetes programs. The staff are doing exactly that.
Yeah.
So wonderful. Okay, we've got questions. You touched on this. A Lake City woman asks, does being a full-blood American Indian increase the chance of diabetes, and would that be passed on to their children even if the husband is not full-blood American?
That's never been adequately studied. It's a very interesting question, but again, kind of gets back to, is it purely a genetic issue? And certainly not. And we see in populations where, some populations like where I'm from, there's a lot of full-blooded tribal members, and other populations there's less full-blooded tribal members, still tremendous disparities in diabetes. Much of it's still rooted in things like commodity food programs and poverty.
Poverty.
Yeah, absolutely.
Well, and it's interesting, we did a show last week that's recorded for May, and I was interacting with a gentleman who had spent some time in West Virginia and Kentucky in true poverty, white area, all white.
Yeah.
And he said, it's all the same. You see, when you see poverty, you see drugs, you see crime, you see unrest, you see poor health care. Poverty is the problem, and what's happening now is, of course, the rich is getting richer and the poor are getting poorer in this country, and it is not a good thing. A Chamberlain woman asked, "What's the prevalence of diabetes?" So, do you answer? You said we don't really know. I know you did the research.
Yeah. So when we look at, for example, in the Dakotas among adults, the prevalence of type 2 diabetes is about twice as high for American Indians as it is for the non-Indian population. So even in the non-Indian population, it's still about 6 or 7% among adults. It's very high, but it's double that for American Indians. Now, there's actually a disparity within the disparity, because the prevalence is twice as high, but the mortality rate is 6 times as high.
The death rate.
Yes, so people are dying from diabetes at a much higher rate if you're American Indian. So our incidence is very high.
They don't have the health care.
Exactly. New cases are very high. But we also don't have the healthy food, because it's not just the medications, it's also healthy food and physical activity.
A Brookings woman says alcoholism can severely affect a diabetic. What is being done to help alcoholism, which might be happening on the reservation and or with diabetics in particular?
Well, one thing that I've seen in many patient visits and certainly a lot of individuals, when you have chronic disease, you see higher rates of depression. And in this country, the most popular self-medication for depression is alcohol intake. Yeah. Alcohol intake worsens your blood sugar, which worsens your depression, which worsens your alcohol intake, which worsens your blood sugar. So in many ways, it's a syndrome, kind of a diabetes, depression, alcohol syndrome. But we don't treat it holistically. Unfortunately, we look at medical care in its silo, mental health care in its silo, and we don't work together. And I think we've proven that model doesn't work. We need a better integrated system looking at mental and physical health.
With some of the tribal diabetes programs, they do have people who are in recovery come into the fitness center. And so it's an effort to try to provide some positive reinforcement for the individuals who are trying to recover.
You made a comment about alcoholism and non-drinkers.
Yeah.
Explain it.
And I do want the opportunity to make very clear that in our populations, we do have a segment of our population that does suffer from addiction and binge drinking. It's really binge drinking that creates most of the health challenges. But by far, we also have the largest population of abstainers, non-drinkers. So we could look at that data set and say American Indians have a problem with alcohol, but we could look at the exact same data set and say American Indians are the most sober population in this state and in this country, because it's true. So how we frame the data is important.
So American Indians are the most sober population.
Absolutely. When you look at abstaining from alcohol, absolutely that's 100% true. So what are the resiliency factors in that segment of our population? So rather than just focusing on the disparity, what are the strength and resiliency factors that we're not tapping into adequately to promote health?
Well, we're not making that point. What do the
Right.
people think?
Right.
We've got 2 questions left and just a little bit of time. Can the Flandreau Santee Sioux go to North Dakota to get health care, and do they have to stay in their tribal health care center? Can you seek out health care anywhere you like if you're traveling? That's a great question.
Yeah.
So let's answer that
Okay,
quickly.
so I teach American Indian health policy, and so
1 minute.
as an American Indian, I can go to any IHS or tribal facility for direct care. But if I need a referral for specialty care, I have to be in my home community
So you have to stay in your home community
for specialty care. But I could be seen anywhere as an American Indian at a tribal or IHS.
Okay. A Sioux Falls woman, Oyate. Sorry. A Oyate Falls woman said, is the government paying for Indian health services in compensation for taking their land? Is there ever a time when it would be paid off, or will it go on forever?
So actually, so it's treaties, right? So it wasn't lost in a war. The land was exchanged for various social services. So it's a prepaid health plan. And the way I put it is, will the treaties ever expire? No. The treaties will expire at the same time the U.S. Constitution expires.
Yes.
So are the treaties old documents? You bet.
You bet.
But the Constitution's even older.
Unless they want the land back.
Sure, that'd be fine with me.
Okay. And now for the winner of tonight's Prairie Doc quiz question. True or false, American Indians and Alaskan Eskimos are twice as likely to be diagnosed with diabetes as the general population? The answer is true. You just heard it from Don. It was Linda Roseboom from Brandon who answered the question correctly. Thank you, Linda, for participating, and a book will be in the mail to you soon. We'll be right back after this.
Listen to your local South Dakota radio station for Prairie Doc Conversations. This program features physicians and other health professionals discussing various medical topics important to you and your family. Ask your local radio station if they broadcast Prairie Doc Conversations.
Thank you for listening. Until next time, stay healthy out there, people. The U.S. is rated as the 10th wealthiest country in the world. The financial website 24/7 Wall Street clarifies that there are 2 reasons we are not called wealthier. 1, we have the world's largest gap between the rich and the poor, with growing poverty. And 2, we are the only developed nation in the world without universally available health care. The second issue of health care goes hand in hand with poverty. Poverty, not ethnicity, is strongly associated with mental health problems, crime, overcrowding, malnutrition, and illness, and affects children the most. All of us would be better off if poverty was reduced. The U.S. Census defines poverty depending on the number in the family. For a single person, poverty means a yearly income below about $12,500. And for a family of 4, that number is about $24,000. In 2016, the U.S. Census found about 13% of our general population is in poverty. Compare that to poverty in Native Americans at 28%, in single-parent families at 27%, in blacks at 26%, in Hispanics at 23%, and in those disabled at 21%. Again, experts clarify the problem is poverty, not ethnicity. Contrast this with the growing billionaire class. A Forbes magazine study stated that the rich are getting richer in a way not witnessed since the first Gilded Age, a century ago. Josh Hoxie, a co-author of the Forbes report, said, "So much money concentrated in so few hands while so many people struggle is not just bad economics, it's a moral crisis." For example, the wealthiest 400 people in the United States now have more money than the total of the lowest 64% of the U.S. population. Poverty is a U.S. humanitarian shortcoming within our own borders, which I personally believe is the core issue about which our political leaders should give their greatest attention. I don't claim to have the answers to poverty, but our country could do better in making available to all affordable health care, satisfying jobs with a living wage, quality and affordable preschool and higher education. I believe political leaders should be intensely studying this issue of poverty and how to support people in need while encouraging opportunity for rewarding work. All of us, including rich and poor alike, could personally try to attack this problem, especially locally. Addressing poverty will also address mental health problems, crime, overcrowding, malnutrition, and illness, and especially the way these issues so severely affect children. Helping all people caught in the trap of poverty will immeasurably raise all boats and make all of us in our society safer and happier. Well, a big thank you to our guests, Valberg Kavingi and Donald Warren, for volunteering to come to our studio in Yeager Hall on the campus of South Dakota State University. This is a difficult and multifaceted subject, and we truly appreciate their input. Thank you.
Thank you.
And now a shameless plug for my new book, Life's Final Season. It makes a great Christmas gift. Several holiday book signings are coming up, and I hope you'll be able to attend one of them. Saturday, November 24th, Ward's Bakery in DeSmet, 9:30 to 11. December 1st, South Dakota Art Museum in Brookings, 10 to noon. Monday, December 10th, Zambro's Variety in Sioux Falls at 7 p.m. Watch for more. We have one coming up in Watertown, I think on the 11th. As we approach the holidays, we will all be exposed to whatever our families and friends bring. Let's make sure it isn't an illness. Get your flu shot. It's important not just for you, but to help protect those around you. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
The discovery and use of vaccines has saved the lives of millions and millions of men, women, and children. Teaching our own immune systems to fight disease is one of the most effective defenses we can have. Vaccines, the history, the myths. Next time, On Call with the Prairie Doc.
For more than a decade, Dr. Holm, in his role as the Prairie Doc, has emerged as a leader of healthcare education and communication in South Dakota and across the country. Every week, Dr. Holm and other medical professionals volunteer many hours to share science-based truth about healthcare on public television, on the radio, in our newspapers, and online. And best of all, everyone has free, easy access to the entire Prairie Doc library. Hi, I'm Jennifer May of Rapid City. As a board member of the Healing Words Foundation, I ask you to consider making a donation. Please help us continue this important work. Go to prairiedoc.org and make a donation today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
And with the ongoing support of these individuals and institutions,
Brookings Health System,
Ophthalmology Limited,
American Academy of Family Physicians Foundation and the South Dakota Academy of Family Physicians,
Avera Heart Hospital,
Dakota Allergy and Asthma,
CoBank,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
Black Hills Medical Society,
Aberdeen District Medical Society,
3rd District Medical Society,
7th District Medical Society,
Dakota Bank,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
Aberdeen Asthma and Allergy,
and Swiftel Communications.